The ventilation strategy, intraoperative lung protective mechanical ventilation is done. Reduces pulmonary complications, length of hospital stay, and mortality. Usually the low tidal volume 6 to 8 ideal body weight. Initially, PEEP of 5 centimeter, or for laparoscopic surgery 8 up to 10 can go. Individualized patient-wise, and surgical factors is there. Plaque to pressure of should be less than 16 millimeter of mercury. FiO2 0.4.5. EtCO2 initial respiratory rate is 8 to titrate to EtCO2 of 40 millimeter of mercury rather than traditional 30 to 35 millimeter of mercury. With raised EtCO2, there is increased tissue perfusion, as I discussed in oxyhemoglobin dissociation curve, and there is some vasodilatation, so that may be increase in tissue perfusion. So we have to do repeated recruitment maneuvers when needed from the beginning, immediately after intubation and at certain intervals, and also after extubation. Lap surgery and steep head down surgery, high peak airway pressure may happen. A patient may go in desaturation. So we may need to change the mode of ventilation to pressure control mode. During emergence, even mechanical ventilation to maintain, minute ventilation to be maintained to eliminate inhalation anesthetics and facilitate rapid emergence. If minute ventilation is not maintained, it will take time and to come out the residual anesthetic gases. Pressure control mode in lithotomy and lap surgery. Pressure support after extubation to prevent airway collapse. The modern machines has a pressure support mode and control part of the control mode. So after extubation, we allow patient to take spontaneous breathing with the lower rate, so the patient can take patient own respiration, but with pressure support.